Thank you very much, Francois. I'm a little bit nervous after such an elegant presentation. And also what makes me nervous is that until Tuesday, I thought I had my story well worked out and the presentation was well done. And I listened to the debate, is Africa ready for treatment? And Mark and his colleagues eloquently argued a lot of things. So, like I said during that presentation, that it confused me because then I had to go back to the presentation and say, are we really ready for this? And that's so, when you see me getting a little bit, the slides not really making a lot of sense, it will be just a confused man who is listening to that. Anyhow, my presentation is going to I'm going to give you the background information. Then we look through the current situation, successes, challenges, lessons learned, and I'll give you the parting thoughts. One of the things before we do this, the questions following the arguments that were being presented, is Africa ready for viral load testing? And the other question that one would like to think about is Africa committed for viral load testing? Will we ever see viral load testing included in routine monitoring of ART patients? These are kind of questions that after the hepatitis C and debate, I kind of went back and I was sitting there in my room, listening to the news, that this was going through my mind and saying, will we be able to really one day see throughout Africa, sub-Saharan Africa, viral load being part of routine testing? Anyway, for those of you, Botswana is the landlocked country, southeast of Zimbabwe. I think Zimbabwe is northeast of So I would say that, and we have a population of 2 million. And the first HIV case that was reported was in 1985. And after that, the story changed. Anyway, the current situation in Botswana is that it's one of those countries that are highly affected by HIV with different populations. Pregnant women, we now are 30%. 1 in 3 that give birth that are pregnant will be HIV positive. We did a study on female sex workers, which there's almost 62%. And men who have sex with men was 13%, was very low. But this study, the challenge with it was that it was actually the respondents were within the age bracket of 19 to maybe 35 to under 40. So it's not really very representative of what we see. So over the years, what we have seen the prevalence of HIV in Botswana increase. And one might ask, with the last survey that we did in 2012, if you call it bias 4, Botswana 18 survey number 4, which was done in 2013, it was 18.5%. The issue with this, I borrowed these slides, when we can acknowledge together, this was from Thomas really in South Africa. These slides we took them a long time ago. If we are to simplify it, it's like this. In the absence of treatment, this is what we have seen. We have seen prevalence go down, and HIV will have increased, of course, because there will be more deaths and new infections will be coming in. However, when you close the tap with ART, you see prevalence going up, as we have seen. So, as you can see, that the prevalence will reduce the death rate, the new infections will reduce them, and the prevalence goes up. So now what we'll do, we'll go back to viral load testing in Botswana. What have we seen? One of the key things for us in Botswana was that if you are led from the situation, the question that I ask myself when I look at other African countries, I really envy them that when they do implement viral load testing, they will have a lot of evidence and plans that are well laid out. When we started, there were no plans and all that. It was like a knee-jerk reaction. But at the same time, I get very scared because if it ain't broke, the Americans say, if it ain't broke, why fix it? Because people are taking treatment. How are you going to convince a politician that people need viral load testing? That's the question that I look at it and say, in the current state of event, what happens? For us, we're very lucky because the political will, we were able to, above the WHO guidelines, be able to include routine viral load monitoring, resistance testing, and other like those are things that initiatives that were included. But this is because it was coming from the top. When the president says something, we all listen, isn't it? So basically, this is where we work with. So currently, the standard of national ART since 2002, the standard of care has been CD4 testing, viral load testing, and for those who fail second-line treatment, we do HIV drug resistance. And we started infant diagnosis way back. We, in 2005, through CDC partnership and collaboration, we moved to TBS, and now it is the standard of diagnosis. We ELISA rapid test became available. Now down the memory line, you know, we started our program in 2000, where it was piloted in Princess Marina Hospital as a concept. And in 2001, the government of Botswana, in collaboration with the Botswana Health HIV Reference Lab, started the new lab in Gaborone. Basically, in 2002, we launched a national program, one of the first in Africa, and it was only started at 4 sites. And let me acknowledge some of my colleagues here. I'm with doctors Haulati, Mataba, Letati, and of course Dr. Mdongo. These are people who sit in the ART guidelines. So if I get stuck along the way, they'll be able to rescue me with the questions and answers that we do. Anyhow, our model of starting the ART, it was started around the satellite clinics, where they ship the specimen to the centralized facility at the laboratory. Then they were shipped to the reference labs. We started off with 2 reference labs. Those are one in Francistown and one in Gaborone. These are the 2 cities. And then, as you can see, Botswana is very fast. To drive from one point to another, it's going to take more than 1,000 kilometers. And also, we have a very extreme temperatures. So with the 2 labs, what we were seeing was that because we're getting specimens being shipped, they were coming long turnaround times. You will see that when you start with Prevalence. Specimen transportation from long distances and under extreme weather temperatures. In Zimbabwe, when you say, I think when you say room temperature in summer, you need 30 degrees Celsius, or maybe 35. In Botswana, it would be 42 degrees Celsius. If you leave your specimen on the bench, they are baking. If you're in Zabong, it's even worse. And in winter, we get temperatures that 32 degrees Celsius in Zabong, and at night we can get -5 degrees. So there's extreme fluctuation of temperatures. If you leave water outside, it will freeze. So these are the challenges. As the program was that, we were facing challenges of specimen integrity, and then of course you have to get the results to people. And one of the things that I should congratulate WHO, because their pragmatic approach of saying, give antiretroviral without laboratory monitoring, was actually one of the fundamental things. Because in our case, laboratory was becoming a bottleneck. So in some cases, at that particular time, they had a model that actually we were able to put more people on treatment. Our model, because it was one of the few first models, when we were asked, the president was asked, how are you going to give ART? He said, do it as in the West. Because if we had not done it the way it was being done, it was if it had failed, people would have said, no, they failed because they didn't do monitoring or that. We were more like a proof of concept. If you're doing something, an experiment, it's a proof of concept. So basically what we were forced to do was to roll out ART, where we take the services closer to the people. And one of the things that we found out, and you will find out, of course, when you do this, is that our turnaround time is affected by a number of factors, amongst them human resources, scarce human resources. And for us at the time, the diamond industry was doing well. So we were able to parachute the solution, recruit from our neighbors. People like Trevor Peter, people like, I think, Charles Casipo, and Tokomo, and many others. People like Tokomo, I trained them. They came through, and so now they're here in Zimbabwe doing a great job. So they'll be able to do that. And now the other guy, Mr. is coming. And we trained actually the regional, and one of our colleagues in the private sector, Shatman, they went through our letter, and we were able to train. Part of that, we trained quite a lot of people in the region. And of course, some of the bosses, our bosses, Dr. Kilnat is here, who is at CBC at the time. Some of us, and we've made really great friends and made good friends throughout the region. So these are some of the things that affected us. So laboratory supplies, we are talking about laboratory blackout. Communication between facilities, specimen transportation and all that. These are the challenges that we face. So for us, this is just taking the services closer to the people. Then the question becomes, which viral load platform? At the time, the platform that was available was Roche, and the biometer was Technicas, and I can't remember the exact name of that. But what happens is that I cannot answer the question of which platform, because it depends on a lot of issues. When we started with the Amplicor, Roche Amplicor, it was actually, the difficult part of it, it needed elaborate infrastructure, where you have to have amplification, detection, and separation rooms. So it was, if you went to a district level in Botswana, which was one, you couldn't really apply it. The viral load platforms also that you do, depends on the price, the cost of the machine, reagents you procure or listen, and the population to be served. And the equipment throughput, I think, the equipment throughput. Because in Botswana, one of the challenges that we are having, HIV affects both the districts and the cities, rural areas and cities equally, or sometimes to greater intensity. Therefore, the challenge is how we best reach those who are in need of treatment in these areas. And sometimes when you go to the facility, you find that it doesn't even, the lab is only one, it's at the back of the hospital. So the question became, what do we do to move forward? This is an example of what happens. Quelling East is one of them. If you count the populations, I stole this slide from one of the presentations. I'm collaborating. I got it from Dr. Hawla's presentation. So basically, you can look at the numbers. If you're in Quelling East, which is a rural area, and you have 57,000, what kind of machine are you going to put there? Gaborone is the capital city. Serowe, Mahalapen, these are some of them. We have rural areas that need high throughput machines. Are we able to put high throughput machines in those? This is the first platform that we used. It used to take 6 hours to get to the results. And we had to have many of them. Those of you who use this platform, you know it was a robust platform that was there. Then another interesting thing, in 2007 we piloted a system, the Kabili system. It's based on ELISA, enzyme activities line based on. This we found is a neat system, which you can actually be able to do because it's ELISA based. It's easy to train people in the Kabili system. We don't talk much about it, but I thought it was a very robust, neat system. It's also a subtype, non-severe. You can do any subtype and be able to do that. So this is one of the systems that we put in the very, very remote and far areas, and it was able to work. The challenge with it was taking 4 days to get to the result. But viral load is never emergency, isn't it? Unless, of course, somebody is failing second line, the confirmatory viral load testing. Then, of course, Roche, having that they came up with a new technology, which is the power sampling, and the TechMan 48. TechMan 48 was new because you could put everything on there. Then we started seeing, now that we multiply, we then introduced Cavity for competition purposes. No, not Cavity, Biomirror, the EasyQ, and all that. Because one of the key things is that when you do this, the design the platforms, you have to be able to do comparative, create a competition so that you can negotiate pricing. Okay? Now the TechMan 96, this is like the state of the art. It's more robotic. You put less human resource. You just need 3 or 4 people to run so many specimens. And it's fully automated, the interface to the IT system. Now where are we with the system? What we see, this is a graph that we can show. When we started, we struggled a little bit. And one of the things is that we have 32 sites that are doing, 33 sites that are doing CD4, and we have 27 that are doing viral load testing. And we have 6 that will be doing EID. We had 2 now, in the next we are decentralizing to 6 more. We preferred more of the same, because of the quality issues and quality assurance issues. We tended to go for the more centralized facility than point of care testing. Even though point of care testing, I'll talk to you later about it, is coming into it, particularly in the CD4, we've seen it become very useful in some areas. So basically this is our capacity. We can be able to run medicine, assuming all things equal, as economists would say. We have a capacity that can last us for the next 5 to 10 years, because it's a small population. Anyhow, this is now where we are. We've dotted all from 2 labs. We have all laboratories. Even now we're moving to the clinical point of care testing. So what we saw, as more and more labs came in, we were able to put more people on treatment. I really love to see how Malawi and those who put people with the WHO's guidance, how they were, I think they were able to go upstream. 1,000 men must have been really done in a very short period of time. But because of the lab infrastructure, with us, this is what we do. So currently we have 245,000. I didn't want to put the slide on the street because yesterday when I had Zim and 1 million people on treatment, I was like, wow, these guys have a real big problem. For us, we are struggling with 245,000, and we are talking about viral load testing. So I went and removed the cost of testing because I didn't want to overwhelm them with the amount of money that is required to do that. The other issue that we should look at is outsourcing. What is the role of private sector? Because private sector can come in handy where we have challenges. I think in developing countries, in resource-limited setting, we've not actually been able to utilize the capacity in private sector and their capacity, partly because of what they do. You know, if sometimes you're a government and you solicit collaboration with the private sector, they kind of fleece you. You know, the tests that usually run for $10, they will charge $30. That's very common in developing countries. So with cumulative death and others, this is just a snapshot of what's happening there. So lessons learned. One of the key lessons that I would encourage people is to have strategic partnerships. For us, for us to have been able to reach this, was not governmental. We had, for instance, for purchase of equipment, we had our CDC Botswana really come in and assist us in procurement of equipment, ACHA, and of course the Ministry of Health. Then development of infrastructure also was CDC, PEFA, and ACHA. One of the things is that because Botswana is small, we know each other and we meet each other. It's always easy to negotiate and discuss, should we do infrastructure or equipment? I think one of the key things for us is that when we have this development of infrastructure is very critical, because you can even expand that. We have seen that with HIV, even though it's a scourge or whatever you call it, that's no good. It actually also helped us develop laboratory capacity. Laboratory systems improved in Botswana because of the advent of advent of that. BHP had short-term training, this is Botswana Harvard Partnership, and the Ministry of Health recruitment of personnel and long-term staff. And of course, this is the program that we centralize with laboratory master training. Training is very critical because it's wherein everything, is it clinical, is it nurse, is it everything, you ought to be able to train and have a system of doing that. For lab, it's even you have to do equality assurance. I'm hoping that. One other key thing that for us worked for us, which I don't know how we are going to do in other countries, is political leaders have shown uncommitted, openly addressing HIV crisis, and availing funds to be able to, for the Ministry of Health. If the presidency avail so much money to the Ministry of Health, assuming it's in the plan, National Development Plan, I think the Ministry of Health, they would avail money to us. So we've been very lucky in that regard. Dr. Kilmans, when he was in his presentation, he talked about good management. One of the key things, money is not always critical, but it's leadership, management, political will, courage. Courage means being able to walk, and instead of just philosophizing or pontificating, you can be able to make a move and say, let me not wait for perfection, let me start, and I'll see what happens. If funds run along the way, somebody says, but at least they try. But if we do over-planning, we could end up not being able to do that. Of course, these are what are very critical. For us also, one other thing, this is just my slide, and my colleagues might just say that I think Botswana responded to the death epidemic rather than actually infection. Because people were dying in a large number. Yes, we responded to the death epidemic. If 33,000 people died in 1 year, for Botswana it never happened. So we were even thinking we are threatened with extinction. So what happened was that when the president came in and said, people are dying in large numbers, we have no other way. It's a small population, 2 million. You lose 33,000. Friends, brothers, sisters are there. So you cannot really sit there. We responded to the death epidemic. Now that people are not dying, how are you going to pressurize the political will to say viral load testing is important? I don't know, you know. So one of the key things, this is what Dr. Moffat, one of also the superintendent of President Marine at the time, the need for treatment. He says, if Botswana failed, Botswana had everything going for it. This is what if people will say, Botswana had everything going for it, and it failed. So why should we help anyone else in Africa? So we were under pressure. I think this is where, when I say to you, I don't envy you because you are responding to people are healthy. And if you were coming to me and say you want to do viral load testing, I'll ask you why. Because people are healthy and they're going back to work. All mutations, you will talk about resistance and all that. How do you convince a non-medical person that resistance is going to do that? That's the strategy of communication. Anyhow, other strengths that we had was laboratory quality assurance services, which is we had to have that because it's one of the key fundamental areas. So the challenge was when we decentralized, sustained quality control and assurance. And this is what worries me with point-of-care testing. We have to really, point-of-care testing has its place in viral load testing, but how do we assure quality if we have 6,000 point-of-care machines in Zim or in Botswana? How would we be able for the panels? How do we deal with it? Do we enroll them in external quality assurance? For us, we started doing a quality assessment, quality assurance panels that we do. What is the role of point-of-care? It's interesting because it was raised. It has its place, but we have to define the model that is going to work in the area of viral load testing. This slide is from Maureen, one of the presentations that you made. If you acknowledge it, it's collaboration. It's from Unity. These are what is in the pipeline for point-of-care testing. We had about Gene Expert the other day, and of course the Samba viral load. And with the Alira Q, we started looking at this. What is their role in the system? Anyhow, now departing thoughts for viral load testing. One of the things that I really think we should think about saving lives. How many of us here go to the hospitals in public sector? How many of us go to hospitals in public sector? Good. Including myself. One of the key things is that I do my test in our laboratory. Why? Because it's accredited. And we want to make sure that we have 4 laboratories that are accredited. The 2 more have that. When you have faith in the public sector, you will be able to do that. How many of us here, if we were HIV, we were on treatment, we would like viral load to be monitored? Every one of us. So the moment we start thinking about money, somebody asked a question, should the cost be the barrier? I don't know. It's a question that we have to really think about. Success is largely dependent on building true capacity. A country like Zim, we are in a very good position to be able to mount viral load testing. And in other countries in Southern Africa, you can be able to do that. What we need is the how do we do it? How do we scale it up? How do we start? And of course, the deficit that has been there, we can increase the deficit for you to be able to run the viral load testing. The other critical thing is coordination and alignment between and among local and international partners.
Yeah.
This is very critical because sometimes partners compete and they create that kind of confusion within the system. But for us, we've been very lucky that when you're a small place, like we've been able to really deal with partners and be able to align them with this. So before I go there, let me share with you the last story, then I'll round up my talk. There was one time when donations, for instance, partners would donate machines to me. One of the companies donated the machine, wanted to donate the machine to the lab. Anyway, at that particular time, we didn't agree. We just said, well, thank you very much for the donation, but we will not be able to take it because it's in the pipeline. The next thing, they went and donated it to the highest office. So one of the directors calls me, Dr. Mine, there's somebody who's been, machines being donated. I'd written a speech that I'm going to dismiss this guy. He said, come, how can you do? When I get there, I see the president. And I say, Your Excellency, I've actually been looking forward to receiving this machine. I wrote a speech which is so eloquent in 5 minutes, less than 5 minutes. And I said, this machine is going to take us to the next level. We took it to the lab. So I said to the guy, pack it in the storeroom because we need to receive it because the president was there. So 2 weeks later, we meet at the National AIDS Council meeting. And he says, how's the machine doing? I said, no, it's still fine. We dust it every day. We are waiting for the time when we can be able to implement it. For us to be able to do viral load testing, please, I would imagine if Robert Mugabe, President Mugabe would say to you, do viral load testing, how many of you would refuse? You have to enlist the biggest people in the country because when they say something, I had received the machine like that. I was so eloquent, smiling, I was shaking the guy. And I was looking at the manager, and he winked at me and said, you couldn't do that. But the president, he said, so we've been able to benefit from that. International organizations have done wonderful work. And this is my last slide. Let me acknowledge the Ministry of Health, CDC Botswana, Archer, Botswana Harvard Partnership, Roche and other partners like UPenn, Baylor, all other universities who've come into Botswana to come and build capacity. Without partners, the world now is a global village. And partnership creates, Botswana's success story, we cannot put it on your government. People think there's just a stash of money somewhere from diamonds, that we are twiddling our fingers, waiting for a disaster to happen. And when disaster happens, we just grab and say, okay, disaster has happened, let's just bankroll the disaster. No, it's not like that. The success has really been largely through all the partners, some of them not mentioned here. Let me declare that the top presentation was sponsored by Roche, but I did not just include their machines because they funded this, because I've talked about Kabini and other machines. But one of the key things I needed to declare so that you know, it's just sucking up to Roche or something like that. Thank you very much.